Hi, everyone. Welcome to Being Patient Brain Talks. I'm Deborah Kahn, founder of Being Patient. We're going to talk today about hallucinations and delusions, which come with many types of dementia. Personally, I've seen it myself. It's very hard when you have a loved one, a family member, or when you're caring for someone and they're experiencing any type of hallucinations. So we thought today what we would do is hear from both a doctor and a patient to talk about their experience, both treating hallucinations and also their story of living with them. So please join me in welcoming Erin. She is Dr. Erin Foff of ACADIA Pharmaceuticals. She works for the company that is developing a treatment, a drug that is right now under FDA review to treat hallucinations related to dementia. And also we have with us Chris Schwilk, who is a person who has been diagnosed with Lewy body dementia. Lewy body is also one of the dementias where hallucinations are quite characteristic of the dementia. Erin, Chris, thank you so much for joining us.
You're welcome. Glad to be with you.
So I think what I want to do first is start with you, Chris. We were talking a little bit about this before we started this interview, but Lewy body is very characteristic of hallucinations. It's like maybe one of the first symptoms patients experience even before memory loss, yet it's also misdiagnosed. We've learned from our community and heard many stories of people being who have Lewy body, but were diagnosed with Alzheimer's disease. So can we hear first what your story is? How were you diagnosed, and what were some of the earlier symptoms you were experiencing?
Sure. I guess my story goes back to about 2014 or 2015. I was a university professor, trained special education teachers. And I could tell in my teaching, my preparation, my grading, that something was off as far back as 2014, 2015. And I mentioned it to my primary care physician, who's known me for, 20, 25 years. And he said, you're probably just getting older. He said, but let's send you for an MRI and make sure you don't have Alzheimer's. Well, they sent me for an MRI and I didn't have Alzheimer's. So I'm like, cool. Okay. Everything's great. Great. Wonderful. But over the next couple of years, work just kept getting more difficult. And my driving was really becoming kind of problematic. Not that I was dangerous. In fact, I'm still driving with the blessing of my neurologist right now. But I began having just not feeling comfortable or having problems with depth perception, seeing things like bugs. I remember sitting and playing cards with my kids and saying, did you just see that big bug run across the table? And they said, Dad, what are you talking about? There's no bug. Those kind of things. But in 2016, my story's complicated in that my diagnosis wasn't straight from, I think I have dementia. But I had PTSD from an event where I'm a scuba instructor. And unfortunately, one of my students passed away during a swimming test in June of 2016 while I was on sabbatical from my teaching job. And from that, I had severe depression, which affected my cognition, and I got treatment at University of Pennsylvania for that. But after they dealt with the PTSD symptoms, my cognition was really, it just wasn't coming back. I couldn't make myself grade. I couldn't make myself plan, and I couldn't answer questions in class.
So sorry, I don't mean to interrupt you, but I want to just back up a little bit. When you said, like, I'm always fascinated in this pre-symptomatic phase, right? It's not when you realize, wow, something must really be wrong, and then you go to a doctor or a neurologist. It's the time before, and what you said was you noticed something was off. How can you describe that a little bit more? Was it your concentration? Was it that you were starting to see, experience hallucinations early? In hindsight, how would you describe that?
Yeah. My neurologist, I have an advantage of being in a biomarker study, so I've got one of the best neurologists on the on the planet, I think, down at Thomas Jefferson Hospital, rather. And she says that for people who, like me, who have a PhD and are in fields that are cognitively demanding, we tend to notice when things are off maybe sooner than some people who don't have that same level of high cognition requirements. So for me, it was that I couldn't answer questions quickly, or my students always said I seem like a Google search engine, that I could give them a website, dating back to anything in any field related to anything that had to do with disabilities for children. And I couldn't do that anymore. Those were the things. I took my students to Washington, D.C. to go visit Gallaudet University. And about 6 months later, I was teaching students in some of them were in the same class that I took. And they said, remember when you got that ticket when we drove into Washington, D.C.? And I'm like, no, my God, I do not remember that I got a ticket. I got a ticket? And they said, well, you didn't actually get pulled over. It was one of those flashy tickets, where a photo ticket for going through a stop sign or something like that. I don't remember it.
Right.
I have no idea what they were even talking about. And I guess I did. I guess I paid it, but I don't remember it. Those kind of things of just missing out on pieces of my life that were just gone, that I couldn't grab, I couldn't recall, I couldn't get back. Even people say, well, you did this. I'm like, you can tell me I did it. I believe you. I just don't remember doing it or having that happening. When I was driving for quite a while, I would experience big trucks coming into my lane.
Oh, that's terrifying.
Scared me to death. And I thought sure that I was done driving at that point.
So were you with other people and you would see a truck coming at you, and would you swerve? I mean, what happened? Yeah,
it was actually coming in, like if I'm on the highway, it's them encroaching on my lane. And I would turn very quickly, like onto the median or into another lane, which scared me and a whole lot of other people around me, and essentially, really scared people that were in the car with me at the time.
And had you been diagnosed with Lewy body at that time?
I had not. It was right before my diagnosis.
So, and Lewy body is characteristically recognizable because the hallucinations tend to come first. So in hindsight, do you think you were having hallucinations before you knew what it was you had dementia? Yeah.
One night I saw a great big bullfrog jump across my lawn in November. Very cold outside. And I'm like, okay, this does not compute. Bullfrogs are not out right now. I don't live near a pond. There should not be a bullfrog in my backyard. What it was my dog had gotten her leash stuck underneath a brick that supported my air conditioner, pulled the brick out, and the brick bounced across the yard, and I thought it was a bullfrog.
Wow.
Those kind of things happen to me a lot, where I see something, but it's not what I think it is.
Yeah.
And I'm getting better at having the perspective of saying, that doesn't make sense. That's not what I think it is. But sometimes still, I don't know what I don't know. Sometimes I don't know if what I'm seeing is a hallucination or whether it's real.
We have a couple of people asking Chris about whether you hallucinate more later in the day, and someone else saying, would you hallucinate more during sundowners? You know, is it common they kind of come out more at nighttime?
Yeah, so I'm still very early in the disease process. My doctor would describe my where I am as kind of prodromal, which is a word I didn't know before. That is, I've been diagnosed very early through by being part of this biomarker study. I had a DAT scan, and they can look at me and say, "Yeah, your biomarkers are consistent with Lewy, and so we can diagnose you with Lewy." I'm not aware that I sundown, but I do know that when I'm tired, I can't distinguish things as clearly as when I'm fresh.
Right.
So, and I think that for some delusions that, you know, just minor delusions that I may have, I think that the same is true. I don't think I have any, you know,
right.
Family members may disagree, but I don't think I have any persistent delusions. Right.
Right. Well, I mean, and often they're not. I mean, I can see it with my own mom, you know, sometimes she thinks people have broken into the house and, you know, but yet sometimes she doesn't do that. And sometimes it's like every day, you know, we have these episodes. And talk to us a little bit about the pattern of hallucinations and delusions with dementia, Erin. You know, no rhyme or reason again, or do we know if there's triggers?
So the great question. So first of all, there may be differences in how hallucinations and delusions present depending on the underlying cause of dementia. So you've already mentioned one example of that. So in the example you've given with dementia with Lewy bodies, hallucinations are very common and in fact can often precede the cognitive problems. That is very different than with other dementing illnesses like Alzheimer's disease. For the most part, in Alzheimer's, hallucinations and delusions tend to occur later in the disease course. And in fact, delusions are a bit more common than hallucinations in the majority of Alzheimer's patients. So the pattern of the hallucinations and delusions may actually give a little bit of a diagnostic clue. Can't rely too much on that.
Can you just define for us the difference, like hallucination versus delusion? What is the difference?
That's great. So hallucinations are when somebody is seeing, hearing, smelling, or otherwise sensing something that isn't really there. So they may taste something that there's nothing in their mouth to taste, see or hear things. Those are the common ones. A delusion is a fixed, the common definition is a fixed false belief. It's when someone is believing something that is not true, no matter how much evidence you present to the contrary. So this may be something along the lines of someone is stealing from me, or my spouse is being unfaithful. So, and they can get a little bit muddled because sometimes if somebody is really fixed on believing that their hallucination is real, it can be hard to decide, is that a hallucination and a delusion or just a hallucination? The key is that you have to ask. You know, one of the difficult things is that these are tough symptoms to talk about, and they don't often get discussed in a clinical setting.
What part of our brain makes us hallucinate? Is it like, I mean, we know the hippocampus is responsible for memory. Is there a hallucination delusion component or?
There is. These are complicated pathways. The back part or the occipital part of our brain is kind of responsible for integrating our visual understanding of the world. So taking those images that our eyes see and turning them into an interpretation. So the type of thing that Chris was talking about, where the car appeared as though it was coming too close into his lane, that kind of misunderstanding of the visual perception is really integrated in that back part of the brain. Delusions are more complex because just even in the nature of the complexity of how they're ingrained into the more of the prefrontal cortex and other parts of the brain mechanism.
So we were talking about too the fact that I know, a lot of people who suffer from delusions or hallucinations are treated with antipsychotics or antidepressants. And what's remarkable to me is none of these medications are made for people with dementia, yet they're prescribed because there's really just nothing else out there. So talk to us a little bit about the drug that ACADIA, where you work, the pharmaceutical that you work at, is now wanting to release onto the market for dementia. It's previously been used, I think, for Parkinsons, but now you're asking the FDA to consider it for dementia.
That's right. So you're dead on that all of the drugs that exist out there right now in the antipsychotic category were really developed for earlier onset psychotic syndromes like schizophrenia. And in fact, they carry some pretty serious and significant safety liabilities in an elderly population. And that's partly why there hasn't really ever been a great demonstration of benefit and risk that would allow that calculation to mean that those drugs are approved and safe for use in elderly patients. Although in essence, you have to work with what you have, and that's what the choices many clinicians have to make. ACADIA has developed pimavanserin as the name of the drug, and it was really tailor-made initially for Parkinson's patients because it hits a chemical pathway in the brain that doesn't affect motor symptoms. And that makes it particularly useful in a Parkinson's population when you already have motor problems. And many of the other antipsychotics have this liability of causing movement problems. What we noticed when we studied pimavanserin in Parkinson's patients was that the Parkinson's patients who also had Parkinson's-related dementia did very well on the drug in terms of their response of their hallucinations and delusions. And that clued us in that maybe the drug would really work very well in a broader dementia population. And that's what we've been studying.
So Chris, have you taken any medications for the hallucinations or delusions that you experience?
Well, I don't know if it's specifically for that. I take rivastigmine. I have 4.6 rivastigmine patch, and I seem to do better now with that. I feel like I've gotten time back. And as I say, I'm still driving. My neurologist sent me for a driving evaluation at the Moss Rehabilitation Clinic in Philadelphia, which I passed. The examiner still wanted to restrict me, and I said, "Well, give me some evidence here. I'm a data kind of guy, But so right now I'm still driving, but yeah, I think it's helped. But who knows?
Yeah.
Too many variables.
Erin, how far off are we? I mean, it's under FDA review. What does that mean? I mean, how long would we have to wait? And is it under clinical trial in people with dementia?
So we completed our clinical trial program that was being used to support the application to the FDA about a year ago now, and then packaged everything up and gave it to the FDA. Their review has right now an actionable date of April 3rd, 2020. That's always subject to change. We're in the midst of a global pandemic. But, it is, and the FDA does recognize that the drug has breakthrough therapy designation. So the recognition is there that there's a really high unmet need because there is nothing approved in this patient population. So we do expect to hear about the outcome of that review in April of 2021.
Okay. As I know that you've studied this topic and you've been in academia as well as working for pharma, but are there strategies like for those of us who don't have access to the medicine and we wait and see if it may work, it's still some months off. For those of us who don't have access, what is your advice? Are there strategies to overcome hallucinations and delusions without taking a pill?
So yes, potentially. So let me walk you through that a little bit. So it should always be in the right clinical situation, there should always be an attempt to try to address hallucinations and delusions through non-pharmacologic means. And really that's even part of the guidelines, to always try things like diversion techniques or non-pharmacologic behavioral interventions. And there are lots of good resources about where caregivers and patients can go to identify and be trained on some of those techniques. And in fact, we use them in our trial too, to see if we could identify patients, for example, who might not need pharmacologic intervention. And then for those patients who really don't respond to that kind of intervention, to Chris's point, there are other medications out there that may not particularly erase or abolish the hallucinations and delusions, but might address some of the downstream manifestations of those symptoms. So Chris mentioned one of them, which is rivastigmine, which is a class of medications called the cholinesterase inhibitors. This boosts the levels of acetylcholine in the brain, and for reasons we don't fully understand, is somewhat helpful and can be somewhat helpful in these symptoms. And many of our patients are already on those medications. Really, for those patients for whom none of those interventions work, or for whom the hallucinations and delusions are dangerous or really, distressing, there's really a need for something else. And that's when we get ourselves in these choices of having to reach for what's there.
Chris, have you adopted any strategies to help you cope when you're having a hallucination? What do you do?
One of the things that I have done since I was diagnosed is I've gotten very into meditation and mindfulness training. So I ask myself when I see something, I just try to be mindful of it. What am I experiencing right now? Ask myself, does this fit with what should be going on around me? Kind of like the bullfrog thing. Bullfrogs aren't around my neighborhood, and they aren't out in November. So that's the best thing that has worked for me, is just being mindful. And meditation has helped me deal with that, to train myself to be more mindful, and also to just deal with life and all that this Lewy stuff is bringing me.
So do you often have someone at home you can say, is this true? Is this really happening?
I do. Yeah, my life's a mess right now. And if if we want to do the soap opera of that, I could, but I do have people around me who can, that I bounce stuff off of and say, does this make sense, or doesn't it make sense?
I mean, the thing that's different about Chris is he seems quite rational about his hallucinations, right? I mean, if I told my mom she was hallucinating and there was not anyone else in the house, she would get really upset with me because she's sure that there is, right? So that's interesting in itself, in terms of the level. So Erin, what do you have to say about that?
That you hit on one of the key features here. Sometimes patients are aware and sometimes patients are not. And Lewy body patients, particularly early in their disease, like Chris, are often aware, and so are Parkinson's patients, often very aware, or can be told and can accept that what they're seeing or experiencing is not real. In situations, particularly with Alzheimer's disease, where the onset of these features is later, when the dementia itself is more severe, patients are often agnostic and unaware of their symptoms. And in fact, trying to convince them otherwise of the lack of reality of their experience can be in itself distressing. And so the techniques to approach a patient with these symptoms are very different depending on whether or not a patient is or is not aware.
Absolutely. I mean, Chris sounds very rational about his hallucinations. I must say.
For now, dial back in 5 years and we'll see.
Yeah. So why do you think, Erin, that pharma hasn't addressed this sooner? I would think, we don't have a cure right now, but this would be one of the top priorities because it seems so common.
Right. That's a hard question to answer. I mean, it's wrapped up in a lot of mixed pieces, and maybe a few of them are that the field has been very focused, and I think with good reason, for a long time on trying to attack the disease. A lot of money and time and effort has been focused on disease modification and trying to find a cure. And inadvertently, we have sort of allowed some of the symptomatic, the care part, not the cure part, slide a little bit to the wayside. And I think there's really been a reawakening in the last 5 to 7 years that care part, that, you know, addressing these things that really impact quality of life, that really impact whether a patient stays home or goes into a nursing home, those have become really critical. And there have been some advances, I think, in how to approach the problem. For example, in the trial that we ran, we made the decision to bring all dementia patients in, as opposed to just patients, for example, with Alzheimer's disease, to really get a sense of the real world utility of the medication. In general, central nervous system clinical trials do not have a very high success rate. And as we're getting better at diagnosis and biomarkers and imaging, I think that will shift and change, but we're just at the beginning of all of that, really.
Is there a dementia that doesn't include hallucinations? It's just doesn't happen? Or does it occur in all dementias?
There are definitely dementias in which hallucinations and delusions are very, very uncommon. One example would be frontotemporal dementia. This is a rare dementia that tends to afflict patients who are younger. It's a very strong behavioral component. And really, you know, somewhere along the lines of 2 to 10% of patients with frontotemporal dementia will get hallucinations and delusions. That's dramatically different than Lewy body, where 70 or 80% of patients will experience hallucinations and delusions. So dementia, as you know, there are so many causes: alcoholism, traumatic brain injury, and so the rate and frequency of these symptoms can be lower in some kinds than others, but you'd find a case in any dementia, hallucinations and delusions, at some point in the literature. It's hard to escape it.
So we were talking earlier that, you know, Parkinson's is probably more closely related to Lewy body than it is to any other dementia. Is that fair to say?
Yes, that's right. They're really on a spectrum with one another that is unique in the sense that the distinction between them clinically is really what started first. If the motor symptoms started first, you have Parkinson's disease. I'm simplifying a bit, but it's pretty close. If the cognitive and neuropsychiatric symptoms started first, then you have dementia with Lewy bodies. Otherwise, they're pretty much on the same spectrum.
Right. So, Chris, do you feel that your symptoms, I mean, you said you were diagnosed maybe 1.5 years ago. When it comes to hallucinations and delusions, are they getting worse? Are they about the same?
At this point, unless I'm delusional, I don't think they're getting worse at this point. I seem to be on a plateau for the last 8 to 12 months, for which I'm very grateful. For right now, I don't think that they're getting worse.
And there's a good question coming in saying, how do we approach our loved one who doesn't believe they're having hallucinations?
That's a tough one. You know, what I used to tell my patients, so I'll just tell you what I tell them, because there's no one size fits all for any particular loved one patient partnership. I used to tell my patients that if there was no harm in their belief to themselves or to anyone else, then not to try to change their mind about the event. So believing that they've seen someone who has passed away, those sorts of things, you let them go, because there's really no benefit to trying to correct the misbelief. For something that is harmful, so for example, if someone firmly believes that they've already taken their medication but they haven't, and you need them to take their medication, then that is the time to sort of employ these other techniques, distract from the acute situation, leave it behind for a few minutes, trying to find other ways to approach during a calmer time. There's these techniques, but only really getting down into that when it's necessary and letting the rest go.
Right. And, you know, and I like your point too, like these strategies, try them first. Not everyone needs medication. I mean, you know, hallucinations are common, and it doesn't mean you need to necessarily be on the medication. But I think what you were implying, Erin, is when it gets really bad and you're putting yourself or others in danger, that's time to consider. Is that right?
That's right. There's just one caveat to that. There's a lot we don't know. So let me maybe just add a little bit of color to that. We know that patients with hallucinations and delusions, even when they're not severe, have a faster decline in cognition. They have a faster transition to nursing home. They actually have higher morbidity and mortality all around. And so, there needs to be a focus of research into whether treating the symptoms when they're earlier is beneficial to preventing some of those outcomes. And maybe just one other little caveat, it can be really easy to identify when a hallucination or delusion is outrightly harmful. But sometimes people miss the actual harm of a minor delusion and hallucination. If someone believes that their food is tainted, they may not eat as much or at all. And that might just seem like a missed meal because the family member doesn't realize that the reason the person's not eating is because they believe something's wrong with their food. So we should be having these conversations more frequently when we're meeting with our doctor, so that then we can delve deeper into what might be some of the reasons why someone is acting a certain way and make sure there's not an indolent symptom there that should be treated.
We were discussing Don Kent earlier, who was recently on Being Patient and had to see 7 neurologists before he was diagnosed with Lewy body because his hallucination was he would eat something and what was salty tasted sweet and what sweet was tasted salty. Now, to be honest, I mean, a lot of neurologists couldn't identify that as a hallucination.
That's right. That would be a hard one, I think, for most non-specialists. And so, part of the message is educating everyone. It's not just about educating your viewers and the patients and the caregivers. It's really about educating the providers. More than half of patients with dementia are not seen in a specialist environment. They're seen in primary care, and that's the only person they'll ever see. And primary care docs have to be well-versed in heart disease and diabetes, and now we're giving them an extra thing to do. So we really need to arm them with the tools to understand this and make sure that they also know when a patient with dementia shows up with these symptoms, we're really obligated to make sure there isn't something else going on. Let's make sure there's not a urinary tract infection or some other medical condition that's causing the symptoms, but ask about them. And then once we've ruled out those things, decide with the patient, with the caregiver, how to proceed with treatment or with some other approach.
And then it's always tricky because a lot of times it's mixed dementias, right? You have more than one dementia, but that's a topic for another talk, I'm afraid. Chris, for you, was it really hard for you to get diagnosed with Lewy body? I mean, it seems like you were exhibiting a lot of the Alzheimer's symptoms, with the memory loss earlier.
Mm-hmm. My story is very different than most. I had the advantage of living very close to a major medical center. And when I went to there was the Hershey Medical Center in Hershey, Pennsylvania. And the neurologist that talked to me there basically advised me at that time, and it's not the case anymore, but to find a different place because they didn't have a cognitive neurologist. And I was grateful to her for that honesty. What took the longest for me was distinguishing between what was depression and anxiety and post-traumatic stress syndrome and what was Lewy body dementia. And I don't know that it's possible to necessarily tease that out, but we know that there's a lot of comorbidity between those things. That is, they exist they often exist together. My depression and my anxiety were debilitating. I ended up in out in Seattle at a outpatient or what do they call them? Partial hospitalization program. And it was there that the psychiatrist there said, I don't think this is PTSD. I think it is depression. I think it's anxiety, but I think you got a whole lot more going on than that. And that's where I got the referral to see a neurologist. I drug my feet on it for a while. I didn't want to know. But my story is really atypical in that I got a quick diagnosis from the time that I actually saw a neurologist to the time that I got a diagnosis of Lewy body was under 3 months, and that's unheard of.
Wow, that's probably the fastest I've ever heard. Actually, we've spoken to people. It's taken 5 years, right? a diagnosis. Well, I want to say thank you both so much. And I'm glad this is being addressed. It's a really hard topic for a lot of us who are facing dementia, whether you are the person diagnosed or a family member. You know, it can be very, very problematic for everyone to see a loved one go through this. Chris, thank you so much for sharing your experience. And Erin, we wish you all the luck. And please let us know when and if you get the FDA approval. We hope that there's something to help people really in need.
Thank you, Deborah. Thanks so much. Thanks,
right,
everyone.
thank you. Thank you for involving me in this today. It's really been neat.
So if you missed any of this interview, please go to our site, beingpatient.com. You also can sign up for our newsletter. We will let you know about upcoming talks. I always love to hear from everyone about what you want to hear about. So please do write us. We really take to heart and consideration the topics you want to know about. Please write us at info@beingpatient.com. We can post that in the chat of this talk. Thanks very much for watching, and we look forward to next time.